And so welcome to all of you joining us. Before we begin our introductions, just thank you for continuing to be a part of the Merit community as best you know, as we are all going through this difficult process of adjusting to a pandemic lifestyle where we're not physically connected, where there may be struggles that we're experiencing professionally and personally, but we're trying to continue these virtual connections. If you are new to Merit or don't know much about us, you can find more about the Merit community at merit.mcmaster.ca. Before I introduce our speaker for this month, I think it's important that we take a second just to acknowledge the land on which I'm located, and which some of you will be located as well, but each of you will need to consider where you are situated at this present time. But it's the traditional land of the Mississauga and the Haudenosaunee, recognized under the Wampum Agreement, the dish with one spoon. I think it's important for us to recognize each time that we gather together, whether virtually or in person, that we don't do so without any kind of history, that we have a view from nowhere. Rather, we need to acknowledge, particularly as leaders and as academics and as scholars, injustices that have come before us, the obligations, the responsibilities that we have to address these things, and how we can, in our health professional roles, in our academic roles, in our leadership and administrative roles, seek to build connection and relationships to the peoples that have come before us, that have been the historical owners and carekeepers of this land, and what we can do to restore those relationships and undo past justices. So if you just want to take a moment to reflect for yourself, I think that can be helpful, and to acknowledge the unique history and where you're located. And so it's my great pleasure to welcome a friend, certainly an enviable person I would love to collaborate with, which is an open invitation, Dr. Schumacher. So Dan Schumacher is an Associate Professor of Pediatrics, an MD, PhD, who is located in the Division of Emergency Medicine at Cincinnati Children's Hospital Medical Center. As a prolific researcher, he also holds a number of administrative roles, including the Education Research Unit and Education Research Scholars Program Co-Director. He is a former program director and program leader, understanding the practical challenges, but supplemented and merged with some of the theoretical and research challenges that he wrestles with on a regular basis. You're going to hear about his work on the future of patient-focused assessment and what resident-sensitive quality measures and EPAs are, and how they relate to our work as health professions, teachers, and educators. But certainly he is a researcher with an august portfolio of research, particularly relevant to competency-based medical education. And so I'm going to stop talking because he has far more interesting and insightful things to say. Over to you, Dan.
So, thank you for the introduction, and thank you guys so much for having me. I'm really looking forward to the discussion. I am actually going to save a good 15 minutes or so at the end for us to really talk. I really want this to be a discussion. Hopefully I will do a mix of saying things that maybe are new, get you thinking in new ways, but hopefully a review of some things that you already know as well. I'm going to try to go light on the review, but knowing that we have a mixed audience, I'm going to try to do an even coverage so that we all can sort of like be on the same page, have a common mental model, and have a good discussion at the end. So I really am going to focus on how I see the future of assessment playing out, and maybe that can be part of the conversation we have at the end. Like, do you guys agree with me, or do you think differently? I have nothing relevant to disclose. So I really think that the goal of medical education is to make sure that the outcomes of training, learner outcomes, prepare those trainees, those graduates, to meet the needs of patients, to meet patient outcomes. I really think that the holy grail is where those two things intersect. And I don't know that we think as much about that intersectionality space as much as maybe we should. And I'll unpack that a little bit. I think medical education has a problem. There's been a number of studies now that suggest that we don't deliver on the promise or the hope of preparing people to meet the needs of their patients. And actually, I'm going to highlight a couple of these articles at a little bit deeper level, just briefly, to hopefully get your buy-in if you're not already thinking in this way. So a lot of people discuss the work of David Ash, who I think that he is really this is the landmark article that got people thinking about the mismatch perhaps between residency training and meeting the needs of patients. And he looked at obstetrical outcomes from about 4,000 obstetricians trained in a little over 100 residency programs. And they found that from public access data, that maternal complication rates were linked to what residency program you trained in for more than 15 years after your training ended. So that imprinting of residency seems to really follow through with you. But it's not just this study that shows this. I'll show you a couple of others. So this comes out of general surgery, and they similarly looked at adverse event rates at top and bottom tertile residencies from almost 350 hospitals over a number of years. And they found that the complication rates between those graduating at the top and the bottom tertile were staggeringly different. Again, 5 years out, 10 years out, 20 years out, that's still that imprinting. Just give you one more example coming out of the internal medicine world and family medicine world, looking at cost of care. This was almost 3,000 physicians providing care to almost 500,000 patients. And the bottom line of this is that they found that if you train in a higher spending residency program, even if you go on to practice in a lower spending environment in the future, you're still a higher spender. And so they can't train this imprinting out of you, even if you go to a system that's a lower spending system. So now I'll pivot a little bit to, this is some work that I've done actually. So this is giving a slight nod to EPAs, which I'll unpack a little bit more in a minute. But we did a study that had 22 pediatric residency programs in the US that assessed their residents using EPAs. These are 17 EPAs, and they assess people throughout residency every 6 months. And one of the time points was at the end of training then. So at graduation, where did they assess them? I'm highlighting just one thing here, behavioral mental health, which is a crisis in the US, just like it is in other places in the world. And at the end of training in this study, only 53% of residents were deemed ready for unsupervised practice in the area of behavioral mental health. This, again, is the type of thing that a general pediatrician is going to see every day in their practice, and that they're going to need to be doing at a higher level than needing some help to do it. So I'm focusing all on just sort of starting with sort of like big data that supports this, to then assessment data that supports this. But there's also reports of the people that are in training and receiving people out of training that also support this. So this was a study that surveyed department chiefs for pediatrics, internal medicine, general surgery, and OB-GYN. They found that almost half of these department chiefs reported deficiencies for recent graduates in managing routine conditions and simple procedures that are encountered often and really germane to the specialty. And then just one last one here. When you ask the residents themselves, they report a gap in their training for caring for common conditions germane to their primary care specialty. This one, again, was looking at internal medicine and family practice. I can keep going with these examples. The bottom line is that I think that we failed to link educational outcomes to patient outcomes. So why do we do this? I think we could detail this a lot if we wanted, but for me, it boils down to two main things. The first is a failure to match training to the needs of patients. So I love this graphic from Julio Frank in The Lancet now a little bit over a decade ago. As John already mentioned, I am a big CBME proponent. And this really stems from my interest in CBME. So, in the traditional model of education, we sort of decide what's the curriculum going to be. We get a bunch of smart physicians and education scientists and, education designers, and we decide this is what the curriculum should be. We develop some objectives around it and we assess them. And we hope that the result of all of that prepares people to provide care to patients and be a good doctor. But as I just showed you, that doesn't always play out that way. So CBME really suggests that we put this, think about the end first, that we identify what do patients need, what the health systems need to be able to serve patients, and then from there define what are the outcomes that people need from training then the competencies to achieve that, and then develop the curriculum around that and assess to make sure that people are doing it. This is the more, to me, sensible way to design things. So the other problem that I think that we have is unwanted variability in assessment. Subjectivity is, germane to workplace assessment, assessing people in the workplace. That's not all bad, but some of it is unwanted. So just give an example here, coming from the work of Jen Kogan at Penn and Eric Holmboe as well. They did a beautiful study where they had people assess residents using a 9-point Likert scale, which is, in a previous world, the common way that we would do this. I recognize that now we're seeing, for you guys, EPA-based assessment, for us, EPA and milestones-based assessment in the US. But this really highlights this study that was done in the previous world of Likert scale rating, really highlights some of the problems that we had. So after supervisors rated the residents, they asked them, what were you thinking when you were rating these residents? And they found 4 themes. This was a qualitative study. The first one is that people had variable frames of reference. A lot of people actually use them. Self is the most common frame of reference that people use. But I can use myself as I currently am, 15, 20 years into practice, myself when I was in their shoes, my ideal self. You can use their peers, their ideal peers, someone that's at a graduating level for an intern. There's all kinds of frames of reference that you can apply to someone. And the frame of reference you use really does influence the decision you make about their performance. They also found that there's high levels of inference. If I'll just give an example. If I were to cross my arms, sit back, does that mean that I am inviting to the patient that I'm talking to, or does that mean that I'm shut off to them and not inviting? Those are very different inferences to draw from the same thing that I'm doing. Variations in choosing the numerical scores. Look, people just said, I have absolutely no idea what these numbers mean. And factors unrelated to performance, right? If someone performed in a way where there's a where I should be calling out their need for working on their development in a certain area, I might not report that because I don't want to deal with the ramifications of it. They might come back to me and say, why'd you rate me that way? They might come back, that might make it to my supervisor, and I don't want to deal with any of that mess. So all of these things are, can factor into sort of this unwanted variability that we have in assessment. So for me, this is all an intro to get to the bottom line of the future of high quality care, in my opinion, depends on better assessment of physician performance. So how have I gone about trying to address this? Well, I believe that there are 2 patient-focused ways of thinking about assessment that are out there in the literature right now. And I'm going to cover a little bit of both of them. Then I'm going to take a step back and put that into some context, and then we'll have some discussion. So I think entrustable professional activities bring the patient to the fore in assessment. And I'll also talk about the quality measures that I've developed that I also think bring the patient to the fore. So recognizing a mixed audience, I won't spend a lot of time detailing what are EPAs, but I want to make sure that in the mixed audience that, that there may not all be Canadians that are living in the competence by design world that understand all of this. So I will cover just a little bit. EPAs are exactly what they sound like. They are professional activities that are core to the profession that someone can be entrusted to do with varying levels of supervision, ultimately without supervision, or the ability to supervise others. I think that EPAs are very much a synthetic way of looking at the world. They put together several different competencies to make a bigger unit of what we do. And I was having a great discussion earlier today with John about this, about how there's pluses and minuses to that, right? Because EPAs are at that higher level, they speak to why I think they are patient-focused way of thinking about assessment, right? A good example from pediatrics of an EPA is care for a well newborn, or I'm a pediatric emergency medicine physician. An EPA for me within pediatrics is managing patients with common acute problems. Those are activities that patients need me to be able to perform to get the care that they need. So a real benefit of EPAs is that they bring the patient right front and center. Whereas in my opinion, not to disparage milestones, because I think these are both and I think they're complementary, but I don't, milestones don't place things into that same context, right? They, you hope that the amalgamation of all of the different competencies and milestones around teamwork and care coordination, and taking a history and doing a physical, you hope that that all gets together to produce the good doctor that can provide the care that patients need, but it's not inherent to the framework. So it's a little bit different in that way. I've already given you a couple of examples of the EPA, so we can just sort of like move past this. So the other way that I think that EPAs bring the patient to the fore is how they're implemented. Most often, as many of you know, they are implemented using some entrustment supervision scale. And I'm just giving one of the early and most basic ones, supervision scales that, you would allow someone to not perform it with full supervision, partial supervision, they can perform it without supervision, or even supervise others. And so this again brings the patient to it, right? That, providing safe care. How much supervision does someone need to make sure that you've got safe, effective patient care on the other side of this, right? So this again is where we can say trainee performance for this EPA can be buttressed, corrected with a higher level of supervision if needed to provide safe, effective patient care. As this graphic from Jen Kogan and Eric Holmbo shows. The other thing that I would point out here is that, this is also where a strength of EPAs that I see is that they are construct aligned, right? So, if I'm a newborn hospitalist, as an example, I know what caring for a well newborn looks like. It's not going to take a lot of faculty development to get me to understand what the EPA care for a well newborn looks like. I know what that practice looks like. It's my job to do it every day. And presumably, I have some sense of how much supervision the trainees I'm working with need or don't need to be able to provide that care. Because again, I know what that care looks like, and I know what I have some idea of what someone would need to be able to do to provide that same care that I provide without supervision. So it's construct aligned. It's aligned with the way that supervisors are already thinking about physician performance. So the one last thing that I'll say here before pivoting away from EPAs to talk about quality measures is that, while this seems so rosy, that, it's just a matter of matching performance to appropriate supervision, I don't think that we always match supervision to what trainees need very well. And I think that we both underdo it and overdo it. And, so even though this is a patient-focused way, in my opinion, of thinking about assessment, we don't execute it very well. So I like the work of Andrea Gingrich, that, she developed this simple sort of graphic that sort of talked about, or sort of identified two sort of spectra that we sort of function on, in terms of our supervisory styles. And on sort of like the x-axis here, you can sort of be, have sort of like on one side, you can have sort of like a shared responsibility for the ward, that you might be willing to let a trainee do something because you're sharing that responsibility with them. Or on the other side, you might say, look, ultimately this patient care depends on me. I'm really going to take a personal responsibility for this. And on this other y-axis, you can sort of, again, have a focus that's more on the patient or more on teaching. And ideally, we would, gravitate toward, something that meets the situation, right? If the patient is going to get good care based off of what the trainee is doing or proposing to do, we probably could be a little bit more hands off, and give them that space. Or if they're not going to receive safe care, we probably should be a little bit more hands on to make sure that the patient does get that safe, effective care that they deserve. But we don't always tailor it very well to that situation, right? We all have our innate propensity to be a little bit more hands-on or hands-off. And, Andrea found in this work that, people that are primarily hands-on or hands-off actually can move to the other sort of like supervisory types. to meet the needs of the current situation. But we do have a predominant way that we go, and I think for those of you that are clinicians, I think if you think about what's your dominant way, that's it's not bad or good, but how much can we flex ourselves out of that to meet the current situation in front of us? I think is something that we could think about more than we sometimes do, perhaps. So EPAs, first way that I think about bringing the patient into the assessment equation. I also think that quality measures are a way of bringing the patient into the assessment equation. This is pretty common in the attending or supervisory physician world, that we use quality measures to assess people's performance, but it's a little bit less common in a lot of specialties in training. Some specialties, have done a better job with this, but by and large, we don't have a lot of quality measures in that function in the training world. So with that gap, we actually sought to develop some quality measures that fit for the work that residents do, and we termed them resident-sensitive quality measures. So what are these? They meet two criteria. The first criteria is that they are important to an illness or a care encounter of interest. And I say by care encounter, I mean, so I work in the emergency department. Our initial measures, as I'll show you, we developed around illnesses, asthma, bronchiolitis, which is a lower respiratory tract illness in children, closed head injury. But that doesn't work for like primary care, where like a care encounter is the more important thing. So again, in pediatrics, your child goes in for a one year health supervision visit. That's not an illness, that's a care encounter. So that's what I mean by care encounter. So they meet two criteria: important to the illness or care encounter of interest, and likely done by or attributable to the resident and not another member of the team or the team collectively. If you're currently saying to yourself, yes, but care is ultimately provided by the team, hold that thought. I'm going to circle back to it in just a moment. Go with me for a minute that it's important to piece out the individual, and I'll unpack that more in just a moment. So we developed these criteria for specific illnesses or care encounters. I said our initial work focused on asthma, bronchiolitis, and closed head injury. I'll show you that data. We now have developed others, but I won't show you that data today. And we developed them through a nominal group technique and then a Delphi. The nominal group technique was getting experts, residents, supervisors together in a room and having them brainstorm everything that they could think of that would meet these two criteria. Nothing was wrong, nothing was right, there was no judgment, it was a laundry list. And then we took all of those good ideas and we put them in a Delphi to help people to prioritize what rose to the top that met these two criteria the best. The examples that or the measures that we have come up with now in peds emergency medicine, peds primary care, internal medicine, and the adult wards, adult internal medicine wards, really focus on a couple of key buckets: appropriate medications and dosing, appropriate documentation of key history and exam findings. In the ED, appropriate discharge guidance, which actually is really important in the ED environment. Not having appropriate discharge guidance or having understood discharge guidance is a reason why patients return to seek unnecessary subsequent care. So that's a pretty important one for the ED. And then especially in the inpatient environment, it was not just appropriate medications and dosing, but also like appropriate orders, like lab orders and radiographic orders and things like that. And in all of the settings, the use of order sets as an idea of getting around standardizing care is seen as the best practice in the prioritization that we saw. So let me just give you an example of how one set of these played out. So again, these are the ones for the pediatric emergency department with asthma, bronchiolitis, and closed head injury. And for each of these, we developed what got prioritized to the top was about 20 or so individual RSQMs for each of these illnesses. And this is showing a composite of those about 20 measures for each of the illnesses. So on the right-hand side of each of these graphs, like the 1.0 would be a resident met all of the measures that they had the opportunity to meet. Whereas on the other side of this, the 0.3, 0.4, that means they met like 30 or 40% of the measures that they had the opportunity to meet. So I think that there are some important take-home points in this data. The most important take-home point to me is that these, as opposed to the ratings that we oftentimes see people, even with good faculty development, ratings of people, residents' performance oftentimes does tend a little bit high. These measures did not tend a little bit high. They actually had a pretty good distribution, that not all residents performed them well. And I think that this is helpful in a couple of ways. One, we identified things that before this, supervisors had said this is important things that the residents should be doing, and then we found that they're not doing it. So that is helpful for giving them feedback to improve their performance in ways that we want them to be performing it. But I also think that from the assessment side of things, this this discerns between residents, right? It's not just that they all were clumped in sort of one area. This really does distinguish the performance of different residents for comparative purposes. I'm a big believer, as we'll get to at the end, and we'll see if we have some discussion around it. I'm a big believer in the best way that we can execute assessment is having different types of data from different sources of data. And that all putting that all together. So this is sort of what some people call programmatic assessment. Putting those different types of data and sources of data together can give us the most complete picture of what someone's performance looks like. So one of the things that we were interested in knowing is, now we have these RSQMs, they behave differently than other types of data that we sometimes see in assessment. What do people do with this data if they are asked to do something with it? So we did this study. That was a qualitative study where we put together a mock resident portfolio and presented it to competency committee members and saw what they did with things. So we aimed for a typical performing resident in the middle of their training. We used a real resident to create this portfolio, actually. So it had milestone ratings, it had EPA ratings, it had written comments across a handful of rotations, and we stripped out the name of the person and the gender. But other than that, it was real data. And then we added quality measures to it. And we did not tell the supervisor, or we did not tell the clinical competency committee members what we were looking for in this study. We just gave them the portfolio, said, review this, think out loud while you're reviewing, what's striking you, what's really standing out to you. And then after it, we asked them questions around what were they prioritizing more or less, what was really probing down to what was standing out to them or not. And we asked about everything. So we did not lie to them. We were interested in how they prioritized things and what they were giving more or less weight to. But we were most interested in what they did with the quality measures. And in the analysis side of things, we honed in on that and discarded some of the things that they said about the other things. And what we found is that almost universally, the CCC members were willing or even enthusiastic with using the RSQMs. And we did not orient them to them ahead of time. They had to do that for themselves. And they did, for the most part, find them to be self-explanatory. And what really stood out to them was something that I had showed you in the previous slide, that the residents did not universally perform well on these. And that stood out to them when residents did not do things that they thought a resident should definitely be doing. It was sticky. It stuck with them. And therefore they tended to prioritize this at least equal to the other data they were seeing, and sometimes even more, because they couldn't get out of their mind that something was missed that they really thought should be done. So I said, put a pin in thinking about the individual for a moment, and I'll come back to it. And this is where I'll come back to it. So when I talk to people about my RSQM work, sometimes they say, look, why are you focusing on the individual? Care is provided by teams. So who is responsible for providing care? I'm talking to you about individual clinicians. A lot of people say that this is really care is provided by the teams. The informatics people would suggest to you that care might be provided by the system, and that if care is not the way that it should be, there's something wrong with how the EHR is supporting individuals and teams, and they put a heavier weight on the EHR failing people. And look, the bottom line is, I think that this is it's not really a both and, but it's a both and all three. I think that we need to focus on each of these, and I think that they're all value added. And just because I'm talking to you about measures that are attributable to the individual, you know, we graduate individuals, we certify individuals, we credential individuals. And I think that we need to, for those reasons, those are all pretty high stakes decisions we make about individuals. I think that those all make us need to wrestle with how do we tease the individual apart from the team, even though we know that ultimately the care that reaches the patient is provided by a team. And I'll just give a quick shout out to, because I see this as a continuum, I'll just give a quick shout out to the work of Stephanie Seebach-Sayer, who I think is doing work that is the next step in this continuum for me. I'm focusing on the individual. Now, some of you may know she's focusing on what she calls coupling or independence. And the bottom line is she's finding that oftentimes care can be attributable to a dyad or sometimes a triad, you know, such as a resident and a supervisor, or maybe a resident and a nurse, or a resident and a nurse and a supervisor. And that's sort of like a microsystem team before you get to the big team. I see all of this as work we need to be doing for different reasons and to improve the care that we're providing and assess at the right microsystem team, macrosystem team, and individual in the way that's all additive to our overall goal of serving the needs of patients and helping people in their development. I had a great conversation with Ronald earlier today about the idea of big data. You know, I think the question is there big data in medical education? Perhaps not. But you know, these things that you can extract from an EHR, like the quality measures, the RSQMs that I'm showing you, those fall on the principles of what we think about as big data, right? Mine information out of a system that has a lot of data points, and so I'm just, there's been a number of people that are making calls for sort of trying to harness the EHR in this way, and we're doing that with our RSQMs right now. So I think that answers another call that's out there right now. I think our work is helping to answer that call. So I'm just going to take a few minutes now that I've sort of laid out how I sort of see how we can be more patient focused in our assessment approaches. I'm hope you'll be willing to take a step back with me and put this into the context of where assessment has been and is going on a larger scale. So this is shifting gears a little bit and asking you to take a step back with me. I love this article from Lambert Schuworth and Kees van de Vleuten from just the end of last year, where they talked about a history of medical education, and they described 3 eras of assessment that we've gone through. And I'm going to unpack each of these a little bit and sort of point to why I think a little bit more of a patient focus might be coming. So these 3 eras are assessment as measurement, assessment as judgment, assessment as a system. So what do each of these mean? Well, assessment as measurement is really what we oftentimes first think about when we think about assessment. It's psychometrics, it's standardized tests. This is really, the 1950s and 60s were, the rise of these things, right? Where good assessment really was numbers that had good validity, reliability. You really could defend them. And look, this still holds true to now, right? We still use high stakes standardized tests, and we still use them for the same, defensibility purposes that they were used, decades ago. That hasn't changed. But what has changed is people's conversations around whether that's where the story ends. So we're doing some work with Ben Kinnear, who's a med-peds physician here in Cincinnati with me, a talented person. I know some of you know his work. So I'll give an example of where that might not be quite enough. Imagine that you are a defense lawyer or a prosecution lawyer, and you go into a courtroom and you concede your opening arguments, you hand the jury a bunch of depositions and a bunch of evidence, and you leave the room. You leave it to them to put together what's the case you're trying to make, why do you think that your side is right, and then for both sides, defense and prosecution, and then decide which they think is correct. We would think that this would be preposterous, right? Clearly, you need someone to argue with you, to argue to you why they think their evidence is correct. And I really think that this is the bridge that says why we are not any longer in the only assessment as measurement world. We need assessment as judgment, that we need words to make sense of these numbers, that we need arguments to make sense of these numbers. And all of these words and arguments, that's all about judgment, right? So this is why we have things like competence committees, right? If ratings could stand alone, we wouldn't need that human judgment, right? To say, well, where did that rating come from? It should we believe it or not? We have a little bit of incomplete data in this way. How can we triangulate between the other data that we have to try to make our best assessment in that area as possible? And I think that the other thing, so not just this collective judgment way of thinking about assessment, but also the subjective, which I love. Brian Hodges, the title of this article is beautiful. This assessment in the post-psychometric area, learning to love the subjective and collective. So it's not just the collective judgment, but it's also the subjective, right? More and more people are talking about the value of written comments and narrative in painting rich pictures that a lot of times people even say make sense of the numbers or the ratings that they have in painting a picture of someone's performance. So I absolutely love this. This is where we are still at today. So each of these eras, we don't ever get away from completely. So we're still with this today. As I say, we have competence committees. A lot of people are using, the value of written comments, but we still have the assessment as measurement piece. So assessment as measurement, assessment as judgment. Where now the current era is assessment as a system, or what some people will call programmatic assessment. And this is just saying what I had said earlier, that we need multiple types of data of different sources and different types to really paint the most complete picture of someone's performance. And this is where I'm going to bring back in where I see, so granted, so EPAs are oftentimes done by a rating, so they're a little bit more assessment as measurement, but hopefully we're gathering some written data about them, so that assessment as judgment. The quality measures I presented to you are clearly they're measures, so they're a little bit more assessment as measurement. But again, I don't think that any of these things can stand alone, and I think that we need all of these different sources of data to do the most complete picture of someone's performance. And I showed you how the quality measures oftentimes don't reflect the way that ratings play out. So what will be the next era of assessment? As I say, the elements of the previous eras have persisted to the next eras that we have experienced. But the further out we get from the earlier eras, the more at risk I think they are. So the assessment as measurement, I really think is at some risk right now. The SAT has come under siege. In the US, the step one USMLE just went from a numbered score to a pass-fail. And recertification exams are starting to look different in the US as well. Both in anesthesia and in pediatrics, we now have this thing called MOCA or MOCA Peds, that you never take a recertification exam again unless you want to. And if you go with the MOCA, there's no single moment high stakes proctored exam. You get questions either monthly or quarterly. You go at your own pace. You can look answers up just like you can in the real world. They can push current content out. I just did some MOCA Peds questions that have COVID content on them. And they really focus on the assessment for learning. That if you get a question wrong, they represent it to you. If you get it wrong a second time, they represent it to you again. The goal is that you learn the things that you should be learning. And so they're not just using it to assess your performance, but they do use it to assess your performance. You need to perform at a certain reasonable level in order to be able to move on. So I think the next phase will likely employ a wide range of data types and means of collecting data, sort of the assessment as a system or programmatic assessment way of doing things. And I have to, although I'm biased, I have to wonder will we get to the point where assessment as learning and improving care becomes the next era? I don't know if you guys will think that is provocative or obvious. To me, it's definitely hopeful that we can keep the patient in the center of the focus for how we're thinking about doing assessment. So I'll just leave you with one concluding thought that to me summarizes all of this point. I love this quote from Allerton Cott. Assessment in the workplace has too long been separated from entrustment to provide patient care. And to me, that's what this is all about. We've got to do a better job of linking these two things. So with there, I said we'd leave about 15 minutes for questions. That's almost exactly what we have. And I'm really hoping we can have a discussion. Tell me what you don't agree with. Tell me what you do agree with. Let's have some fun.
Thanks so much, Dan. That was a tour de force, a lot of information, but staged in a way that makes a really compelling narrative. Certainly, I'm going to monitor the chat for questions, so you need to focus just on continuing to give us smart and provocative responses, but others can come off mute and pose a question directly if they'd like. I'd like to hear a little bit more about the operations around the RSQM. Does an assessor have to move through the chart or through the patient encounters that day or that week in order to capture this? And do you have, so it's a two-parter, so it's a bit of a double barrel question. And if you have an EMR, is there any type of intelligent automation to extract this data for expert subjective assessment?
Yes. So I did not touch about this, but we do have two types of RSQMs. We have the ones that can be automated, can be automatically extracted. That's a subset of them. And we have developed the automation around doing that. And matter of fact, in my setting here, we have asthma measures that spit out to us every month for all of the residents, just automatically set up to do that. We also have ones, as I talked to you about, some of these being focused on appropriate key documentation things, that requires reading the note. And so where we are at for operationalizing, so for proof of concept, we did chart reviews to sort of, identify some of these things. But where we're at now is using natural language processing to be able to also automatically extract these out of the EHR. So yes, automation is the end goal for either of these, one way or another.
Talk to me. And I was waiting for a chance for people to jump in, but now I'm going to probably monopolize your time, which is sometimes I want to, and I hear you provoke me. I believe the narrative and where you're taking this in terms of moving away from the tidiness of the psychometrics of these assessments into the more meaningful outcomes, supporting where residents are, and more significantly, supporting best care for our patients. But at least in Canada, I suspect that the environment in the US is similar, that regulators and certifying bodies have a fixation on tell me that they passed a test and show me that there's good complex stats around that. And we want to know the number. We're not so concerned with how the patients are doing, but tell us that we can stand behind this, because that's the nature of certification in a number of professions and has been the long history. So you're talking to us about changing culture within side. What is about the external facing conversations we need to have in order to make regulators buy into this evolving way of understanding assessment?
Well, I think my overarching thought in this area is that we need a couple of brave regulators to be leaders. And I will say, so I don't want to out any individual regulatory bodies, but I do know that there are some that are moving in this direction and will be saying that they're moving in this direction in the US in the coming years. And look, Canada has already said that they are all in on EPAs, right? So I think that, the competence by design, I think that these regulatory bodies that I have in mind in the US that will use this for certification decisions in the future, I think that, those brave people will show that it is okay. And I'm hoping that part of this conversation will help us challenge some of the things that we sometimes don't talk about as much as we should, right? We know that there are physicians who struggle to pass board exams, but are actually very good doctors. And we know that there are people that that pass the board exams that actually aren't very good doctors. And, so like, granted, these people are the minority, and so these tests seem to work for the large majority in the middle, but they're not perfect, right? And I think that when we talk about these defensible, high stakes, if you sue me, they'll stand up in a court of law, right? Like no exaggeration, right? Like that's how we think about these things. But they're not perfect. They have their flaws, and so we just need to answer questions around what is sufficient reliability and validity for things like work-based assessment, and how does how does judgment factor into this, right? Judgment is not bad, right? Our smart brains can assimilate things in a better than a system can. Matter of fact, the system is going to be trained by us, right? So yeah.
I definitely agree, and that's why we're doing all the CAPTCHA work for Google and its driving cars when we have to authenticate. I'm going to turn to Dr. Chan, who has a question.
Yeah, thank you very much for a great presentation and summarizing a really huge body of literature. So kudos to you for a fantastic talk. My question is really around continuing professional development, and I wanted to ask you, like if we're just doing low stakes assessment constantly, like with MOCA, right? What does it look like when someone's really falling off the rails? Like what would the ramifications in your mind, what should the ramifications be? Because sure, you don't get recertified, but you've still got a job, you've got a roster of patients. If someone is noticeably flailing, what would you see that future looking like in order to get them back on track? Like if you were to design the optimal system?
Yeah. Well, so in one sense, I don't know that is terribly different than the world that we currently live in, which may not be ideal, but I think it could be initially handled the same way, right? So like for MOCA and MOCA Peds, if you are, at least in Peds, actually I can't speak for anesthesia, but at least in Peds, if you are not performing well enough on those questions, you revert back to this standardized high stakes exam, actually. And the question is how many people will have to revert back to that. I don't know, but that's, so that's one way of doing this catch-all. But I think that your question is, is a little bit bigger picture than that. And for me, this gets into a bigger conversation around what I think we would optimally be doing at the transitions between training right now, right? So, in other words, if we are, let's say we're using EPAs to decide that someone can graduate or sit for a certification exam, this will get to questions around, so in Peds, we have 17 EPAs. What if you're meeting the target that we have for graduation for 15, but not 17? And the two that you're not, you're close, and it's good enough for us to let you graduate and sit for a certification exam. We could just end there, or we could partner with people and say, you know what, the area actually you fell short in is behavioral mental health. We know that half of people fall short in that. We've actually developed some type of a plan of working with you to continue your development in that way, as we've done for half the people that we know are graduating that also have this need, right? And to me, this gets, Teresa, at your question of, we could do the same type of thing when people are falling behind, right? Like we could have more just-in-time ways of supporting people and building out these skills, especially for common deficiencies, at minimum, right? Again, I'm sorry to keep using the example of behavioral mental health, but I think it's a great example of that's a common deficiency. And why would we not want to have ways that we can support people's ongoing development after training in that area?
There's a writing question from Dr. Martin, who has done a lot of work on EPAs here at McMaster and elsewhere. Her question, and if I get this wrong, Leslie, please modify it as best you can. So if outcomes are coming from chart reviews, or have you envisioned a process for using these to coach or feedback to trainees to help guide their learning? So it's an assessment for learning rather than assessment of learning type of dichotomy question.
Yep. Yeah. So we definitely have thought about this, but we have not started feeding this back to residents yet because we felt like doing the proof of concept, knowing that this is measuring what we think they are measuring, And making sure that we have that right is we really want to have that pretty tight before we start feeding it back to them. But these automated measures that I talked about actually are already for asthma are already automated in a way that we could, what I get back, I think we could provide to the residents as well. We have not only how are they meeting the measure, but also if they did not meet the measure, why, as well as the clinical encounter number that they can actually go back in the chart and look it up and decide for themselves, this got it wrong or this got it right, and to really feed their improvement, right? Yeah, so we do see that as important, and the only reason we have done it is not because the only reason we haven't done it yet is not because I don't think it's important. It's because I want to make sure that we have a high level of confidence in the data before we give the opportunity to lose residents entirely, right? We know that when people get data about their performance, that if they do not see it as theirs, you probably have lost them forever in being able to give them feedback because they don't trust the system that you have. So we're just being overly cautious, even though for some of these, I think we probably already could be doing it.
Okay, we probably have a chance for maybe one or two more questions. I'm going to be a bit of an education nerd here and ask you to dig in a little bit. I was impressed with those curves. They almost look normal distribution for your RSQMs. Why, or what are you hypothesizing? You may not know why. What are you hypothesizing is that? Because in all of our other work-based assessments, we see a range restriction, a right skew, and they don't look normal at all. It's using authentic data. It's the most authentic data that we have. Is it something about that authentic data, or is it something about the pilot or the novelty of it in your system? What would you ascribe those really nice distributions to?
Yeah, I mean, I sort of agree with you that, I mean, obviously I have my bias, but I do think it's authentic data, right? Like either people did this or they didn't do it. There's not much bias to layer on that, right? They did it or they didn't do it, which is one of the reasons why competency committee members in our qualitative study were more willing to use this, right? They said that, they either did or they didn't do it, right? They weren't, they weren't willing to give them sometimes they said, I want to know why they didn't do it. But they were reluctant to give them the benefit of the doubt, right? So I do think that, and I'll just say one other thing about this. So this is asking you to recall what the curves looked like, and yes, they did have a little bit more of a normal distribution, but the asthma curves actually slanted a little bit toward a higher performance, so actually I have a hypothesis for why that was. We had actually a asthma quality improvement initiative underway during the study in the ED that was targeted at the ED in general. And it seems like this did permeate to the level of the residents, actually. And I think that's why some of their performance was higher, is because I think that we captured how a quality improvement process can improve resident performance on these unintentionally. There was not a quality improvement process for care for the other two illnesses. And so, but I think that what asthma shows is that once you start focusing on these things, you can probably improve people's performance on them.
All right, this is our last question, and we'll try to get you out on the hour. And John Lynn has asked two questions, so good luck there, Dan. The first is around mimicking what we see in industry. So you have workplace automated measures, so just-in-time type of phenomenon used by Amazon, by most manufacturing organizations. So how can we use the data in implementation so that it doesn't feel that every patient encounter is a high stakes and electronically observed event? So how do we smooth some of that piece? And then the second part of the question, and John, I hope I'm getting these questions right. There's a little bit of unpacking that I'm doing. How do we ensure psychological safety to try newly learned concepts and put into patient care practice if it feels that the system is tracking your every move, that this is a 1984 type of moment? And there's my own editorialization on top of that, so apologies.
Yeah, I mean, is this a big question? I don't have the answer, but I do have thoughts. So I do think that AI especially is actually sort of pushing the envelope on this, right? When we can have cameras places and be able to not only watch people but also train systems how to see what they're doing or hear what they're saying and make judgments about it and use that as assessment data. I do think that this is a risk in the brave new world that we're entering into, for me, I think that we don't want everything to be high stakes and electronically observed. I think we want to do this in a way that is psychologically safe. Right now, sometimes your supervisor observes you, sometimes they don't. I think if we're going to use, AI and things like that as a way of assessment, I think it's got to be on top of the table, not under the table. I think it's got to be known that, you know what I mean? We are using the camera to observe you right now, and things like, but we're not doing that all the time. And, it's not a totally covert thing. I totally agree that psychological safety and doing right by the trainee trumps everything. But I think that this gives us a lot to think about in terms of how we play out the brave new world that we're going into for assessment. And by the way, for other people that are interested in reading or hearing more about this, Brian Hodges has actually written a little bit about this and actually given some talks that you can find online about AI in medicine. And he even ventures into he had a great perspectives piece in Perspectives on Medical Education at the end of last year about AI in assessment.
So that's all the time we have for. I would thank you, Dr. Schumacher. Just a lovely talk, provocative, asking us to think about what we're doing now and also think about what we can do better. I'll remind you that if this is a talk that you wish a colleague or a trainee had been a part of, it will shortly be up on our YouTube channel after we do some post-production work. And then the last little bit of housekeeping I want to remind you is that June 9th is the Norman Education Research Day, affectionately known as NERD. We'd invite you to come and see all of the scholarship and research being conducted by colleagues and peers across the Faculty of Health Sciences, and to join us for our opening plenary. Pim Tunison from Maastricht is going to be presenting. That video will be available in advance so that you do not necessarily have to get up at 8 a.m. and you can watch it, or you can decide to get up at 8 a.m. and watch it pre-recorded and then join us for a live Q&A beginning at 9 a.m. Eastern Standard Time. So thank you all for joining us. We hope to see you at Norman Education Research Day, June 9th. Take care.